Thank you very much for inviting me to this amazing Congress and to see your beautiful country. This is my second time in Egypt, and I really love this country, your hospitality, your culture, your history. Today, I will talk about digital innovations in ophthalmology and talk about telehealth, artificial intelligence, and robotics. I am a retina specialist at the University of Southern California in Los Angeles. I specialize in retina, but my real passion is to create drugs and be involved in technology to help our patients who are visually impaired. I have no relevant financial disclosures. I'm a board member of our American Academy on Vision Rehabilitation. I'm on board of directors for 2 nonprofits that are dedicated to vision impairment, and I'm the chairperson on the CCOI for Vision Rehabilitation, which deals with AI in our country and regulating AI in ophthalmology. This is a quick overview of what I'll be discussing today in digital health and ophthalmology. I'll be talking about demographics, goals and scope of digital health, implications post-pandemic, telemedicine, remote monitoring and devices, AI, robotics, and future challenges and perspectives. Why is this important? When you look at the numbers, it's staggering. By 2050, over 2.1 billion people worldwide will be over 60. What does this mean for us in eye care? The aging of the population increases the health burden of chronic conditions such as macular degeneration, diabetes, and glaucoma. When you think about the associated office visits with regular monitoring and ongoing treatment, this really amounts to insurmountable healthcare costs. And technology can help us control these costs while improving diagnosis and treatment. What are the goals of digital health? Just to define, digital health is the convergence of digital technologies with healthcare, and society to enhance the efficiency of our healthcare delivery. The goals are to improve access, reduce inefficiencies, increase quality while reducing costs. Really, the goal is for a personalized scope and precise healthcare for our patients. The broad scope of digital health includes categories, some of which that I will not be discussing, which is mobile health, health IT, and personalized medicine. However, I will touch on telehealth and telemedicine, devices, AI, and robotics. When you looked at the digital health and did a PubMed search prior to the pandemic, there's about 15,000 articles prior to COVID. But after the pandemic, there's been over 2.1 million articles if you looked in June of last year. The annual healthcare growth rate for the mobile health market is approximately 29% yearly, and it's thought to be worth about $317 billion US by the year 2027. When you think about 86% of the global population have smartphones. A lot of what I'll be discussing is in the paper, which I collaborate on with several of our members globally in this digital technology paper in PRER. Post-COVID-19, we had increased public staff exposure risks, increased waiting times, and treatment delays. Telehealth can help us in terms of mitigating risk and providing more efficient and, more importantly, equitable distribution of limited healthcare resources while reducing patient journey times and increasing quality of care. Telemedicine is the remote evaluation of patients by clinicians. Post-pandemic, telehealth, for example, in the US, rose from 11% to over 73%. Key factors affecting telemedicine is to reduce the public health risk. And in ophthalmology, when you think about how close we are to physically being in front of our patients, telehealth is a viable option. In addition, clinic workflow limitations also pose logistical nightmares. And in America, modifications on reimbursement has really prompted telehealth to be adopted. In telehealth, it's really important to have good virtual triage. And in order to do this, you have to have a strategy for managing healthcare prior to the patients arriving into your clinic or emergency room. And the key to successful triage is risk stratification. based on clearly defined requirements. And in ophthalmology, this would be included in terms of visual acuity, intraocular pressure, as well as imaging. Reliable, cost-effective, and operator-friendly data import system is very important to telehealth. There's two ways that you can process your data. In Model A, you have a trained person to read the collected images that you take. And in Model B, you can use machine learning or AI to process these images. Different countries have embraced telehealth to help in their eye care. In Scotland, they used telehealth and found that they were able to diagnose patients remotely in 20% without even a need for a visit. And now in Scotland, over 3/4 of all referrals come electronically to the hospital. In the NHS model in the United Kingdom, they've shown that 52% of patients did not even need to come in to see the specialists who are going to come in because of having telemedicine. And they found that 14% of those patients, just by imaging alone, they stratified them in terms of needing an urgent referral. And post-implementation of telehealth in the UK, they avoided over 50% of unnecessary referrals. When you think about countries that have limited resources, telehealth is really important to be able to risk stratify and get the patients in on time as needed. In addition, patients also benefit by reducing their patient journey time. They actually reduce their clinic visit by 3- to 4-fold in terms of time when you're using telehealth. What are the telehealth applications in different disease states? In diabetes, by 2030, nearly 600 million people will have diabetes. The global prevalence is 9.3 in 2019, and this accounts for nearly 5% of all global blindness. Diabetic retinopathy screening with fundus photos has been done with trained graders in many different countries, including United Kingdom and Singapore. In England, where they have 82% of this 2 million population is now screened using, there's 16 screening centers using dilated photos, and now diabetes is not the leading cause of blindness in the UK, just because they've adopted telehealth. And in Singapore, 1/3 of diabetic patients have diabetic retinopathy, and they screened nearly 200,000 patients at 18 centers. And they found that with screening, you can actually tell the patient within an hour whether they have diabetic retinopathy. There have been many other centers in America that have used telehealth for diabetic screening as well. What about macular degeneration? Well, in the US, there's 14% risk of early AMD and 3% for late AMD. And analysis in 2018 suggested that teleophthalmology is just as effective as face-to-face for screening for AMD. Another study showed that in macular degeneration, there was no statistically significant difference in patient waiting times to diagnostic tests and treatment when you have AMD using the telehealth model. And more importantly, when you look at visual outcomes, there was no significant difference in visual outcomes between groups using telehealth versus the face-to-face model. ROP, this is very dear to many of the people and doctors in here. And as you know, annually 30,000 children lose sight from ROP worldwide. And unfortunately, the prevalence is increasing. And as you know, ROP is a preventable disease in terms of vision loss. So in 2000, the very first store and for telemed system using wide field digital imaging was implemented. And it showed that the sensitivity increased from clinicians diagnosing it from 0.46% to 0.86% in terms of sensitivity. So using this type of model telehealth, as you know in the room, telemedicine is really critical for ROP screening. And SunDrop was another pivotal study that showed the shortage of ROP experts that expanded to 6 NICUs in the San Francisco area, using nearly 30,000 images from 1,200 eyes, showed that there was nearly 100% sensitivity and 99.8% specificity showing to screen for ROP. Another global pandemic that is on the horizon is myopia. There's 650 million people that suffer worldwide from insufficient or no refractive correction globally. Uncorrected refractive errors account for 43% of all visual impairments worldwide. And when you think about the optometrist to patient ratio, and in some low income countries being 1 to 600,000 people, it's really hard to screen for myopia without using telemedicine. Myopic choroidal neovascularization occurs in nearly 11% of patients who have pathologic myopia. And as you know, this can cause blindness that's irreversible and can benefit by using telemedicine. Glaucoma is another leading cause of irreversible blindness, affecting 64 million patients. And by 2040, the incidence of glaucoma, or the prevalence, is going to increase to 112 million people. And unfortunately, because early chronic glaucoma is asymptomatic, this makes diagnosis difficult. And detection of early disease requires experienced ophthalmologists, curtailing the cost effectiveness in glaucoma screening. Fundus photos, intraocular pressure, and visual field data are needed for teleophthalmology, and this increases the glaucoma screening sensitivity in primary healthcare, especially in resource-depleted areas. And some of the largest teleophthalmology glaucoma studies have found that 87% agreement on disease stratification. And there have been numerous telescreening glaucoma programs that I've outlined here. In cornea, infectious keratitis is a leading cause of corneal blindness, especially in developing countries. And smartphone attachments using a mobile platform has been used to diagnose corneal abrasions and ulcers in Thailand. So now I'll talk about remote and in-home monitoring. So in Retina, for example, we've used AMSR grids and patient self-reported outcomes, which are quite subjective and low sensitivity. New and future in-home tests in Retina include iPhone and cell phone photos, in-phone smartphone apps, home monitoring with hyperacuity tests and in-home OCT. And for glaucoma as well, there's been home monitoring and home tonometry and contact lens. And I'll also talk about wearables. So on smartphone devices, peak vision and DI portable microscope has been employed to screen people. In Africa, it was used to screen peak vision in over 80,000 children and adults, and was able to screen for many retinal conditions just using a smartphone and a very easy add-on. In Retina, 2 FDA-approved hyperacuity tests have been approved for mobile devices. One is My Vision Track, and the other one is called Eye. And this uses shape discrimination hyperacuity tests to monitor for changes in macular degeneration, as well as diabetic maculopathy. We also use hyperacuity perimetry testing for C home device in AMD. And this is FDA approved to detect new neovascular AMD, and it has improved detection compared to standard care, which is the AMSR grid. In glaucoma, there have been much innovation in terms of in-home monitoring. One is the Eye Care Home Tonometer, which is a disposable electromagnetic propulsion device that touches the cornea. It is limited in high astigmatism or abnormal corneal thickness, and it tends to overestimate the IOP relative to the Goldmann. And you can see that on the figure on the right. Sensimed is a contact lens, which is called triggerfish contact lens. It's a wireless ocular telemetry sensor, and it's using a contact lens, and it's well tolerated in 24-hour wear time. And it's limited if the cornea has high curvature. Now, in-home monitoring device, which is internally placed in the eye, is iMate. This is not available in the US, but is available in Europe. This is an implantable wireless IOP transducer. The external source for power and IOP data recording, you can see he's holding the external recorder unit. And the sensor is a MEMS system. It's sheathed in silicone, and it's placed in the ciliary sulcus done at the time of cataract surgery. A small study with N of 22 shows the greatest variability of IOP in the AM and least at night, and it was well tolerated in a 1-year study. And this is really important when you think about our patients who have keratoprosthesis. You can't monitor their intraocular pressure because when you touch the keratoprosthesis, you're not able to know what the true pressure inside the eye. However, with the iMate, which is internal, you can get accurate sensings of their intraocular pressure. This is only available in Europe at this time. Now I'll switch gears a little bit and talk about virtual versus augmented reality. Virtual reality offers a digital recreation of real life setting, whereas augmented reality or AR delivers virtual elements and then overlay to the real world. What does this mean? VR recreates real life environment. However, it's completely immersive experience. So when you're wearing a VR device, you're putting something on your head and you cannot see the world around you other than what's created by the device. Whereas in AR, you wear the device, but you can still see what's in front of you. It overlays on top of the real image. And I'll show you that in just a second. So in strabismus, they've actually used virtual reality. There's 2 devices that have been used in strabismus. Cyberdome is a 3D VR system that tests binocularity and correlates with the amblyoscope. There's another headset called FOVE, and this simulates normal strabismus diagnosis by testing virtually while tracking the patient's eye movements and allows for automated measurements of ocular deviation comparable to prism testing. What about in amblyopia? Here's where I think VR really has great efficiency, and it's also been FDA approved with 2 devices. And how does VR work? It encourages binocular vision instead of monocular vision in terms of standard occlusive patching. So as you know, we patch right now with using bandage, and we're basically patching the dominant eye, forcing the weaker eye to see. But however, this is monocular. In VR treatment, we are actually using binocularity and forcing both eyes to work together using the VR device. And in 10 studies with 459 patients, it showed that this is actually beneficial to the regular occlusive patching. And this is best for refractive amblyopia, not so much for strabismic or occlusive amblyopia. I talked about this morning, but many of you weren't here this morning, so I put this in this lecture this afternoon. So the first device that was cleared by our FDA in the US was in 2021. The study included 105 patients aged 4 to 7, and these patients used the headset for 1 hour daily, 6 days a week for 12 weeks. And the control group was just using the regular glasses. And this showed an improvement of 1.8 lines versus the control of 0.8 lines. So 1 line of improvement over this last 12 weeks. And for each of these treatments, the kid can choose whatever content that they want to watch, any type of cartoons or film. And so how does this work? The headset presents a blurrier picture to the stronger eye and a clearer picture to the weaker eye, but it does not completely block out the stronger eye. So during the video, the patient is forced to use both eyes binocularly. And this is really important in terms of encouraging binocular vision. The second device that was approved by the FDA is CureSight, which is made by Novasight. And this works in a similar mechanism. However, it uses 3D glasses that you put on and you're looking at a screen. So it's not completely immersive. And this was tested in 103 patients aged 4 to 9. And these patients wore the VR device 90 minutes a day for 5 days a week for 16 weeks. And then the control group was patching 2 hours a day for 7 days a week. And this showed that there was an improvement of 2.8 lines versus the control of 2.3 lines. And the patients, 93% of them, of the children, chose CureSight over patching. And I do think, as you know in the room, it's difficult to get kids to patch because of how their friends might see them. And you're also giving them the choice of the content to wear. So you're going to really improve compliance when the child is able to choose what content that they're wearing. So another AR device so what we talked about is VR so far, but AR is also used in surgery. We've tested Clarity, which is made by Bionics. It's a tethered headset, and you wear this on top. It's a heads-up display where you can see what you're operating on through the headset. And they've used this for cataract and retina surgery. I do think because it's tethered and it's heavy, after, I would say, half an hour, it becomes quite heavy on your head. So I'm going to switch gears a little bit and talk about AI. So AI is programs with the ability to learn and reason like humans. And there's a subset of AI called machine learning. And the part that's really applicable to ophthalmology is deep learning. Deep learning uses neural networks that are used in image recognition, speech, computer vision applications. And it's used in very image-intensive fields in medicine, such as ophthalmology, radiology, pathology, and dermatology. Well, look at this fundus picture. What do you think we can predict from this? Would you be surprised by just looking at, if we took a picture of your fundus image, we'd be able to tell you how old you are, whether you're male or female, what your cardiovascular risk is. Can you believe that? We can even tell your blood pressure. That is true. Using AI, we can predict all of these: age, gender, smoking, blood pressure, cardiac events. And there are recent papers showing that we can predict the risk of dementia. So where does this play in? Well, I really think in diabetes, AI can be really a game changer. As we know, in terms of tele-ophthalmology and telescreening, we have so many patients around the world who have diabetes who never have an eye exam. So when you look at, there's a staggering number that 85% of adults living with diabetes do not get an annual eye exam. I recently saw a patient in my clinic who had had good insurance for 20 years, but his doctor just never told him to get an eye exam and came in with bilateral retinal detachments. He was an executive. He had no idea that he had severe diabetic retinopathy. And this is, in someone who has great insurance. Imagine all the people around the world who don't even have access to healthcare. So I do think AI allows us to have health equity. So there's been rigorous validation for use of AI in diabetic retinopathy. When you look at here, all the way on the left here, it shows a board-certified ophthalmologist in clinic. And I will show you with the next slide, it's easier to see. Now, board ophthalmologists can have a sensitivity of picking up diabetes in the eye between 33 and 73%. That's not great, because in those patients where you're picking up only 1/3 of them, there's many of them who have diabetes that are going miss. And the AI system was able to achieve 87% sensitivity and 90% specificity on the first AI system that was FDA cleared in 2018. So with AI, we can actually have 90% of the patients who have diabetes can actually get screened for diabetic retinopathy. And imagine all the cases of blindness that would be mitigated by using AI. So this was the first AI that was FDA approved, called IDX. And it's a pretty easy device to use. Someone just with a high school degree can operate it. And within several minutes, it will tell the provider whether the patient has diabetic retinopathy. And this is done in an undilated state. So patients in a family health clinic going to see their doctor, if it's in their general clinic, they can take a picture and tell the patient whether they need to see an ophthalmologist. Now, I just wanted to differentiate assistive versus autonomous AI. Assistive is where the AI is working with you in clinic. The clinician is there. You use it to help you quantify, like OCTs, for example. Autonomous AI is where I think the real power is, because you can have these standalone machines without the doctor being there, and it can generate the output of telling that family doctor, hey, your patient has diabetic retinopathy. You don't need to see an ophthalmologist to be able to diagnose and screen. So I really do think this will really address the health inequity around the world if we can have this machine in remote settings. So this has been designed and validated in primary care. I'm working with Michael Abramoff, who is the inventor of the IDX, and he's put the machine in multiple academic centers around the country, and we're trying to do studies showing how it can really help prevent health disparities in terms of diabetes. When you look at this, this is a map of the US. On the left of eye care availability, you can see all the ophthalmologists are on the coast, and there's a dearth of ophthalmologists in the center part of our country. But if you look at the center part of the need, where the red resides, where we really need ophthalmologists, we don't have ophthalmologists. And so if you see the graph all the way on the right, it shows that little blue part. AI can account for that proportion that is that there's a workforce gap where there's just no ophthalmologists there. So AI can help us in terms of diagnosis as well as staging. And in diabetes, AI can also predict the treatment. Like when you're going to give VEGF treatments, we can actually predict it from AI algorithms, whether that eye is going to respond to diabetic macular edema treatment with VEGF therapy. So macular degeneration, we use AI to classify drusen, pseudodrusen, pigment epithelial detachments, geographic atrophy, and there's been segmentation models that can help you quantify ERM, subretinal fluid, and this is a better classification, more accurate than using a live retinal physician. And deep learning has been used in the OCD, this landmark that showed that predict eyes will go on to neovascular AMD with great confidence of a sensitivity of 0.8. So in ROP, AI has been really game-changing. The IROP Research Consortium that was started at Casey in Oregon first started with 12 academic centers to develop better methods for diagnosing, understanding, and treating ROP through computer image-based analysis. And with this AI system, it is able to diagnose with 95% diagnostic accuracy, comparable to those of expert clinicians that only fare between 79 to 99%. So automated image analysis for deep learning for ROP will improve efficiency, accuracy, and objectivity, as well as tell us not only the diagnosis, but the predictive risk and disease development. They showed that looking at capillary segmentation models using these CNN networks, which is computational neural networks, they came with a sensitivity of 0.9. So it can tell you just by taking an image of what's the likelihood of this eye going to predict ROP, even if there is no clinical features on the first exam. So in ROP, semi-automatic platforms include an ROP tool, retinal image multiscalar analysis, and IRP Research Consortium. One second here. I'm almost done. So in myopia, by 2015, it's projected that 50% of the world will have myopia, and 1 billion people will have high myopia. And this has been really interesting in this model. They were allowed, using about 1,000 children in Singapore, they used 3 algorithms to predict who is going to develop high myopia. And it actually allowed for prediction of high myopia in teenage years, 5 years after the fundus image without cycloplegic refraction. So they were able to predict 5 years out which eyes were going to become highly myopic, and they identified these at-risk patients to start timely treatment. My last subject will be robotics in VR surgery. There's been 16 groups that have developed robotics in VR surgery or retinal surgery. There's major classifications of robotic systems in VR surgery include robot-assisted, co-manipulated, teleoperated, partially and fully automated systems. The first one is smart forceps or micron instruments. These are handheld micro manipulators that reduce tremors and negate unintended movements. Another robotic device is co-manipulated. This is called the steady hand eye robot, which is at Hopkins. And the surgeon and robot simultaneously control the surgical tool, which aids in tremor negation. The third model is teleoperated. These are the precise surgical system where the surgeon controls the robotic system. This is a master-slave design where the computer system directs commands to a motion controller. And so the surgeon in this model is operating and controlling the system. And this has been used to cannulate veins. It has been used to deliver drug delivery. And the next step up is Iris, which is fully or partially automated, which is integration of robotic system and viewing system. And here the robot actually controls the surgery. So the surgeon is able to influence it and override it. But in this system, the robot is actually taking AI images like OCT and directly feeding it into the system as to where to peel membranes, for example. So this is an example of ERM segmentation overlay that is used in the operating room to figure out where to peel. So the goal of robotics is towards fully automated surgery. As in autonomous cars, it's thought to reduce the number of crashes by 94%. And I'll just finish up talking about future challenges and perspectives. I'll skip that slide, but I just wanted to talk about what the challenges are in terms of ROP and AI. When you look at the circles that center around this, we're looking at data, availability, interpretability, the quality. Is the data generalizable? How can we integrate this AI data into your clinic? Is this algorithm that we're using, is it safe? Who owns the data? And what about privacy concerns? So many people have asked about how AI will benefit them as patients. Will this exacerbate health disparities? What will happen with their data? And is there a racial bias? And who's liable and who pays for this? So in the US, we have developed a lot of guidelines to regulate AI. There's been, and you can see all of these measures in terms of standards of care, ethics, bias mitigation, and there's even been this consortium that's been developed to garner and regulate AI in our country. So in summary, telemedicine can improve screening, triage, and timely patient management. Remote devices and headsets and diagnosis for therapy in home, in clinic, and surgery. AI, particularly deep learning, plays a pivotal role in eye care diagnosis, including in diabetes, AMD, glaucoma, and ROP. And robotic innovations improve surgical precision and employ varying levels of automation. And AI's future in eye care is going to be shaped by an interplay of stakeholders and issues such as data metrics, privacy, data sharing, and ownership. Thank you very much.